Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you so much for joining our Jet Foundation Virtual Family Workshop Series. For those of you who may not know me, my name is Nick Jacobs, and I am a program associate here at the Jet Foundation. I've been a part of the organization for almost 2 years now. We're really excited to have Dr. Carol Weber with us today, who will be speaking about cardiology care in Duchenne muscular dystrophy patients. For any questions you may have, please drop them in the chat section below, and Dr. Weber will answer some of those after the presentation. We're just going to wait a few more minutes and allow other attendees to join before we begin. Please wait shortly for the presentation, and thank you all for joining us today. And I'm going to pass that on to Dr. Weber in a few minutes. For those of you who are just joining us, thank you so much for joining Jet Foundation's Virtual Family Workshop Series. For those of you who may not know me, my name is Nick Jacobs, and I am Jet Foundation's Program Associate and have been a part of the organization for almost 2 years now. We're very excited to have Dr. Carol Weber with us today, who will be speaking about cardiology care in Duchenne muscular dystrophy patients. For any questions you may have, please drop them in the chat section below, and Dr. Weber will answer some after the presentation. We're just going to wait a few more minutes and allow some other attendees to join, and then we will begin. Thank you so much for your patience. All right, now that we have all attendees, we're gonna, without further ado, we're gonna pass it on to Dr. Weber and enjoy. Thank you, guys.
Good afternoon. Thank you so much for joining this webinar. My name is Carol Whitley Weber, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. The title of the webinar today is Understanding More About DMD Cardiac Care. The goals of the talk are to provide an overview of cardiac involvement in DMD and to discuss recommendations for cardiac screening. I want to make you all comfortable as to what to expect when you come to the cardiologist's office. The focus of the discussion will then be on cardiac testing and the use of cardiac medications in DMD. To start, the heart is a muscle. DMD affects your son's muscles, and the heart is a muscle too. As he gets older, there are two problems that can develop with your son's heart. The first is cardiomyopathy. Your son's heart muscle can become weak over time and not pump properly. Cardio means heart, myo means muscle, and pathy means pathology or abnormality. And therefore, cardiomyopathy is abnormality in the heart muscle. When we talk about cardiomyopathy, some of the terminology that we use can be confusing. What you may hear discussed is the ejection fraction. What ejection fraction is the amount of blood pumped out of the ventricle with each beat divided by the total amount of blood in the ventricle multiplied by 100%. And this is the ejection fraction. A normal ejection fraction is greater than 55%, meaning every time the heart fills, when it squeezes or ejects, 55% of the blood is ejected. Mild dysfunction of the ventricle is an ejection fraction of 45 to 54%, moderate 30 to 44%, and severe less than 30%. So I wanted you all to become familiar with some of the terminology we use when we talk about decreased function of the heart. This is images from an echocardiogram, which is an ultrasound of the heart. This is something you will become familiar with as you come to our office for visits. What's depicted on the left is a normal four-chamber view of the heart: the right atrium, the right ventricle, the left atrium, and the left ventricle. As you can see, when I play this video, this represents normal squeeze or contractility of the heart. On the right, what we can see is dilated cardiomyopathy. So what you can see is the chamber on the left. This is the left atrium and the left ventricle. Again, they're bigger than the right side, so they're dilated. And when I play the video, you can see that the left side of the heart or the left ventricle does not squeeze or function normally. This is an example of a dilated cardiomyopathy, so a larger heart that doesn't squeeze normally. The other issue your son may have over time is they may have issues with the heart rate or rhythm. This is a depiction of how the heart conducts electricity or the heart beats. The beat of the heart starts normally in the right atrium with the electrical impulse moving down the atrium, and then the electrical impulse passes through what's called the AV node. So you can see starts at the sinus node here, moves through the atria, down through the AV node, and then the ventricles. What's depicted down here is a strip from an electrocardiogram. This is something else you will see as you come to the cardiologist's office. And so this strip represents how the heart beats or conducts electricity. A normal regular rhythm is called sinus rhythm. With regards to heart rhythm problems, there are a few different types. Tachycardia is when the heart rate is too fast. An example of this is depicted here, and it's called sinus tachycardia. So it's a regular rhythm, it's just faster than normal. The heart can beat too slowly. This is called bradycardia, and this is depicted here. Sinus bradycardia is a regular rhythm that's just too slow. An arrhythmia is when the heart is beating in an abnormal way. The picture here is an example of non-sustained ventricular tachycardia, so a fast abnormal rhythm coming from the ventricle or the pumping chambers of the heart. In DMD, we can see two things. We can see sinus tachycardia, so an inappropriately increased heart rate for age. And we can also see something called non-sustained ventricular tachycardia, particularly over time as the heart function decreases. These two things go hand in hand. So what does cardiac screening mean? So cardiac screening means your child's heart is evaluated. So who should care for your son's heart? So typically this is a cardiologist or a heart doctor. There are pediatric cardiologists and there are adult cardiologists. And it may be that early on after your son's diagnosis that they're having cardiac testing in association with their neuromuscular testing, but over time it's really important that you meet a cardiologist. So when should cardiology care begin? In 2018, guidelines for the care of patients with Duchenne muscular dystrophy were published, and this is what we follow. This is a figure from those recommendations with regards to cardiac screening. So the current recommendation is that your son has cardiac testing basically at the time of diagnosis. Now, it's true that boys are getting diagnosed younger and younger, but it's still important to connect with a cardiologist to form that relationship early on. So we do recommend a baseline cardiology evaluation at the time of diagnosis. And then this includes meeting us, a cardiologist, and reviewing medical history, doing a physical exam, and doing some cardiac testing, which I'll explain further in just a little bit. We then recommend that your son sees us every year moving forward. There are times when we may see you and your son more often than yearly. This would be in the setting of symptoms that may be related to the heart. This may be in association of needing surgery, like scoliosis surgery as an example. We like to perform repeat cardiac testing around the time of a major surgery. And also over time, if the heart function starts decreasing, we do like to see the boys more often, typically every 6 months, more so if we are adjusting medications or are there any concerns. So yearly assessment is what we recommend, but this may be adjusted over time. With regards to what type of cardiologist your son should see, so pediatric cardiologists, pediatric cardiologists typically see patients up until around age 21. Now, if we meet when your son is younger and follow your son for several years, we'll start talking about the concept of transition in the teenage years around age 16 and expect to transition around the age of 21. So ultimately, with regards to cardiac care, your son will have to transition from a pediatric to an adult cardiologist. Now, this may differ at different centers, but at CHOP, this is what we recommend. So just to reiterate, cardiac care should begin at diagnosis and should occur at least yearly. More often if major surgery is going to occur, and more often if cardiac dysfunction or arrhythmia is found. So what tests will my son have when they come to the cardiologist? So there are several tests that are considered routine as far as cardiac assessment go. The first is an electrocardiogram. So this I showed you an example of. This is a test that measures the electrical activity of the heart and records the heart's rhythm on a moving strip of paper. An EKG is done standard basically at every visit with the cardiologist. A Holter monitor is a battery-operated portable device that measures and records the heart's activity continuously for 24 to 48 hours or longer. This is a test that we typically begin doing around age 10 years of age as a baseline. The benefit of this is that we're recording the heart rhythm for a longer period of time, and we can evaluate for arrhythmias. An EKG just captures the heart rhythm for a few seconds, whereas a Holter monitor measures the heart rhythm for anywhere between 24 and 48 hours. As far as the most appropriate timing for doing a Holter monitor, we don't know for sure what the right answer to that is, but here at CHOP, we typically start Holter monitoring routinely at age 10, but we may do it sooner if we're seeing that the heart function is changing or there's any symptoms reported that make us suspicious for an arrhythmia. This is something your son would go home with from clinic and that you would return after the test was complete. Another test that's considered standard of care at a cardiologist visit is an echocardiogram. I also showed you an example of this. An echocardiogram is an ultrasound evaluation of the heart and helps us to evaluate the heart structure and function. It is typically done at every visit, though over time, as your son ages, we may transition to the use of cardiac MRI for assessment of heart function, and I'll explain that in just a few minutes. The advantages of an echocardiogram or an ultrasound is that they're readily available and can be done in clinic, and they're often pretty quick. Some of the disadvantages we face with the use of echocardiogram is that the image quality can change over time. So as your son moves into the wheelchair and has more limited ability, it can be more challenging to get all of the views that we need. And it's not very good for assessment of the right ventricle, so the right pumping chamber of the heart. And so because of these reasons, we tend to use other assessments of cardiac function over time. This image is just one example of the way the image looks on the screen that you'll see if you're sitting there in clinic, and this is another example. So I've already showed you 3 different views that we get with the use of echocardiogram. So it's an ultrasound test, and we can look at the heart in different views and get an assessment of the function. A cardiac MRI is an imaging test that uses radio waves, magnets, and a computer to create detailed pictures of the heart. It's typically done yearly to every 2 years, starting around age 8 to 10. The guidelines that I just referred to that were published in 2018 recommended that we use a cardiac MRI as the routine surveillance of heart function starting around this age, given the more detailed evaluation that we can get. Some of the advantages of the cardiac MRI is that there's less limitation with image quality, better assessment of the right ventricle, and it can give us more specific information about the heart muscle itself. And I'm just going to show you an example of this and talk a little bit more about this. So on the MRI, we can look for something called delayed enhancement, which represents fibrosis. So what we know about in DMD is that dystrophin abnormalities, which is the fundamental problem, the lack of dystrophin, leads to fibrofatty replacement of the heart muscle cells, the cardiac myocytes. And so they basically change from normal contractile muscle to fibrosis or scar. And this is something we've learned developed over time. This process has actually been found to follow a unique pattern where it starts on the left side of the heart out on like the lateral or outward wall and kind of moves in towards the ventricular septum, or the wall that separates the 2 pumping chambers. And what we've learned is that this process of developing fibrosis can actually develop before we see changes in the heart function. So as you can see, it can be helpful for us to do the cardiac MRI to find changes in the heart muscle that are there before the heart function or heart squeeze overtly changes, and we could guide our management from there. This is just showing you a picture from an MRI, just to give you a sense of what the pictures look like. The top represents a heart without any sort of fibrosis or delayed enhancement, and the bottom represents a heart that does have that fibrosis. So you can see the difference. This sort of black area here is the normal heart muscle, whereas in this picture, you can see how it's changed to white. So that represents fibrosis or scar. So that is one of the advantages with cardiac MRI, is getting that detailed information. However, there are some disadvantages. This is not a test routinely done in cardiac clinic, so you're usually coming a different day to get this test done. It does involve an IV placement, which some of the boys don't like, of course, but the IV placement is crucial in order to get that specific information about the scar or fibrosis. The test is long. It's longer than an echo. It's about an hour. And some people do get claustrophobic in the MRI scanner, which is depicted here. And that can be a problem, though at a children's hospital, as you can imagine, we have support in place to help get kids through this type of test. Our patients are able to wear video goggles while they're in the scanner and watch a video. And in fact, as part of our clinic specifically, we have our child life team help us engage with our younger patients so that we can do this test at a younger age without sedation. At our program, we don't typically sedate children for this type of test, so we wait until they're old enough to do this test without sedation. So moving on to talk about the question of, will my son have to take cardiac medication? So it is true that over time, we are likely going to suggest your son is on several heart medications, and we're going to talk about that further right now. So what medications will be recommended for my son? So the medications highlighted are the ones that I'm going to talk a little bit more about. So steroids you're already familiar with. So steroids, prednisone, deflazacort are standard of care for DMD patients at this time. There's data that suggests that the use of steroids delays the onset and progression of cardiomyopathy, so we are supportive of the use of steroids. The next in the list of medications, the ACE inhibitors, aldosterone antagonists, beta blockers, diuretics, and digoxin are all cardiac-specific medications. I'm not going to spend much time talking about diuretics or digoxin. Those are medications that we typically don't have to use until the heart function decreases severely. So next, I'm going to move on and talk about some of the more commonly prescribed cardiac medications. So an ACE inhibitor. So an ACE inhibitor is something you've probably heard about, and you've heard probably families talking about. So I want to talk further about what this medication actually is. This figure on the right, I'm going to show you in the next couple of slides. The reason I'm showing you this figure is just to mention that when the heart function starts decreasing, there's a whole series of pathways and compensatory mechanisms in the body that get upregulated to help the heart compensate it. Early on, these compensatory mechanisms are good, but after a long period of time, they're not so good. And so we have several heart medications that help augment this pathway, one of which is an ACE inhibitor, and that's depicted in this part of the process. So an ACE inhibitor is a medication that slows the activity of the enzyme ACE, which decreases the production of a hormone called angiotensin II. And what angiotensin II can do is it can cause vasoconstriction, so narrowing of the blood vessels, and it can cause remodeling or abnormal remodeling of the heart. So we want to prevent those things. When you use an ACE inhibitor, what you get as a result is that the blood vessels enlarge or dilate and the blood pressure is reduced. Now, you may know of someone on an ACE inhibitor for management of high blood pressure. Now, we, of course, would consider an ACE inhibitor if your son had high blood pressure, maybe as a result of using steroids. But we use this actually in the absence of high blood pressure to manage heart dysfunction. And in fact, we're starting to use this medication earlier on before we see dysfunction. I'll get to that in just a second. So several examples of ACE inhibitors are captopril, enalapril, and lisinopril. You may have heard of these. So when do we start ACE inhibitors? So this is a really good question. So we definitely would start a cardiac medication, including an ACE inhibitor, if we see heart dysfunction. However, we have data that I'll show you in a second that if you start an ACE inhibitor before heart dysfunction develops, that you may be able to delay the onset and progression of that. And given this, we often start an ACE inhibitor by age 10. Now, we may start sooner if we're seeing heart dysfunction by echo sooner, or if, let's say, we do the cardiac MRI and we're seeing that fibrosis that I mentioned. So we may start it before age 10, but typically by age 10 in our program, we have suggested an ACE inhibitor. With regards to side effects, so what are the things we have to think about? Well, it is a blood pressure lowering medication, so we do follow the blood pressure afterwards. Because of the way it works, it can lead to a rise of the potassium level in the blood. And so we do have your son get blood work within a couple weeks of starting this medication to make sure that the potassium level and the kidney function are still normal. With regards to the age of studying, so there are a couple studies in the literature that were published several years ago now that looked at a different type of ACE inhibitor, so perindopril. This was done in Europe. These two studies tested a group of boys with DMD, and what they did is they started an ACE inhibitor in the setting of normal function. And what they found is that those that were on an ACE inhibitor compared to boys with DMD that were not on an ACE inhibitor, that the ACE inhibitor sort of delayed the onset of the heart muscle problem, the cardiomyopathy, and the decline in function. And there were several studies that this group did on this. And this is the data that has prompted our guidelines to suggest that we start this medication by age 10. The reason for age 10 is that this study and others have shown that we actually can see dysfunction in the heart earlier than that. And so this is sort of the earliest age that we feel makes sense to start this medication. There are, of course, other medications that we may talk about as we continue to follow your son over time. I would say the ACE inhibitor is the first medication that's usually started, and the other two medications that I'm going to mention are started after the ACE inhibitor is started and probably increased. Another class of medication is called aldosterone antagonists. And what they are is they're receptor antagonists at the mineralocorticoid receptor. So now this is the same figure I showed you on the last slide, and the ACE inhibitor is up here, while the aldosterone antagonist is down here. So it just works on a different part of this pathway that I mentioned to you. Antagonism of these receptors inhibits sodium resorption in the kidneys, and so it's actually a weak diuretic. It has a pretty weak effect on that, so it can make your son sort of urinate a little bit more, but it's such a weak diuretic that we really don't use it for that purpose. We use it for purposes of the heart remodeling, as this figure alludes to. The different types of aldosterone antagonists that you may hear about are called amplironone and spironolactone. So when do we start these medications? So again, this is a cardiac medication that we would start if we're seeing heart dysfunction, meaning if we're seeing a decline in the way the heart is squeezing, either by echo or MRI. However, we now have data that tells us that it may make sense to start this medication before we're seeing a decrease in the heart function. So if we do that cardiac MRI test, let's say your son is 8 or 9 and we're actually seeing some fibrosis, there's data that suggests that by starting amplironone or aldosterone that we may be able to delay the onset of dysfunction. And so this is another medication that your son might be on at a younger age and before we're seeing overt changes in the function. So with the idea that we're starting medication sort of in a prophylactic way. With regards to side effects, this particular class of medication can also affect the way your kidneys function and can also lead to a higher potassium level. And so we also have to check blood work routinely within a couple weeks of starting this medication as well. So with any medication addition with an ACE inhibitor or an aldosterone antagonist, and actually any dose adjustment, we're going to ask your son to get blood work. I mentioned, we have some data. This is another study that I'm just going to mention briefly that basically looked at compared boys taking amplironone versus boys not taking amplironone, and looked at SCAR, the fibrosis by MRI, and decline in function. And they found that those that were started on this medication actually, again, had a delay in onset and progression of that heart dysfunction. And so this has supported our earlier consideration of this medication. The last class of medications that I'm going to talk about are beta blockers. So beta blockers are competitive antagonists that block the receptor sites for the endogenous catecholamine, so like epinephrine and adrenaline. So if you think about your sort of fight or flight response, the sympathetic nervous system gets upregulated, well, beta blocker is sort of blunts that. It's sort of the opposite effect. Beta blockers, again, are represented in this figure sort of up here, the same figure that I showed you on other slides. Certain examples of beta blockers that you might have heard about or your son might be taking already are carvedilol and metoprolol. So when to start? So typically beta blockers are started when we are starting to see actual dysfunction. So when we are seeing a decline in the way the heart is squeezing, we don't typically start beta blockers prophylactically, meaning there's no age by which we definitely start it. We don't often start it, when we see fibrosis in the absence of dysfunction. So the other two medications are typically started first, and this may be sort of the third medication that we start. I will say, as I mentioned earlier on in the talk, there are times where we see sinus tachycardia, so an inappropriately fast heart rate, and we might discuss, and we think that if the heart is just beating faster than it should for longer periods of time, that's not necessarily a good thing. And so we may use a beta blocker for that. And also, we may use a beta blocker if we're seeing that arrhythmia that I showed you earlier on in the talk, the non-sustained ventricular tachycardia. So there are several indications for the use of beta blockers. As far as side effects, so these are medications that can also lower the blood pressure, so we have to monitor that. There's really no specific lab evaluation that we have to do for the beta blocker, but depending on the type of beta blocker used, there can be some issues in kids who have asthma as a baseline, so we'll need to know that. It can sort of potentially exacerbate asthma. So that's, of course, why we do a full history and before we start any medication. So beta blockers are another type of heart medication that we may use. So to summarize, there are several different types of heart medications that you may hear about over time when you come to your yearly cardiac visit. There are now 2 heart medications that we may start before we see a decline or change in the heart function. Whenever we start a heart medication, we are probably going to see you a little more often in that interval. And we are going to ask you to get some blood work done routinely as well after initiation and up titration. So the other thing that I wanted to mention is that at times, unfortunately, we do see that the heart muscle weakens quite a bit as the boys age. We don't have good ways at this time of predicting which boys will have what degree of dysfunction at what age. But what I wanted you to know is that if the heart function does decline significantly to the severe range, and we think that your son is symptomatic from that, there are several things that we may talk about. And these are, of course, complex discussions. All the more reason why it really helps us to form a connection and a relationship early on so we can face these challenges together if they do occur. But there are times that we use home IV medications when the heart function is decreased, and that we discuss the implantation of a implantable cardioverter defibrillator, also abbreviated ICD for arrhythmia management. And then finally, there are times where we might talk about a ventricular assist device, which is a pump that we put in the heart. Now, again, we are just really studying and learning more about how to use these therapies effectively in the DMD population. And so they're complex discussions, but I wanted you to hear about them. And, finally, what I wanted to mention is obviously there's so many studies going on about different gene therapies and other ways to sort of treat DMD. And we don't know how that all those studies and new therapies will ultimately affect the heart and heart muscle. Of course, we're hopeful that all of these therapies that help keep all of the muscles strong will keep the heart muscle strong over time. But we're constantly learning new things every day. So with that being said, I wanted to thank you all for taking the time to listen to me speak today. And my contact information is seen here. You can reach out to me by email. There's also my clinic phone number. The picture there is the picture you'll see if you look me up on the CHOP website. So now that I've done sort of getting through what I wanted to talk to you about, I will have time for questions. Thank you again so much for listening today.
Thank you so much, Dr. Weber. And I think we're going to pass it on to questions now.
All right, I see a question that popped up. And the question is, my son is transitioning. Do you think we should get a cardiac MRI? I assume by transitioning, do you mean, I'm going to take that as meaning transitioning from a pediatric to an adult cardiologist. So if so, I think a cardiac MRI is a reasonable test to have done. If your son is going to be seeing a new cardiologist soon, it might make sense to have that cardiologist order the test so that they're the one that gets that test and can help interpret that test as well and can make a decision, as to adjust his heart medications if he needs any. Sometimes transition is a tough time to get tests done because you want the new provider to see those tests. So I think it does make sense to talk about a cardiac MRI if he hasn't already had one with his new provider. So another question has come up. So that question is, what is the recommended age for heart medications? So the shortest answer is that there are some, it sort of depends. So there are some heart medications that we are starting to initiate by age 10 years in the absence of sort of overt dysfunction on cardiac testing. And that recommendation is definitely something something that has come up more in recent guidelines. So guidelines published in 2018, and even guidelines published like in 2017. And so if your son is older, when they were younger, it might not have been the recommendation, meaning historically we've waited for the heart to show signs of dysfunction prior to starting medication. But we've learned more about that, and that also that there's certain medications that if they're started early, may be able to prevent the onset and progression of dysfunction. And so at this time, for younger patients, we are considering at least one, if not two, heart medications prior to dysfunction. Once we see dysfunction, so regardless of age, we're likely to start at least two, if not three, cardiac medications. So the answer to that question is it's variable, but there are times now that we are starting heart medications for patients that are younger. So the next question is the IV medication recommended for EF below 20%, will it be beneficial? So, so the slide that I had there that says IV medication. So there are times when the function is decreased. So in the low, so when it's severely decreased, so that would be less than 20 to 30% for an ejection fraction, that oral medications are not sufficient to prevent symptoms. And so there are times when a patient is very sick from dysfunction and very symptomatic that we consider IV medication. IV medication is an end stage discussion. There are times when, let's say, there's an acute change in function where a patient might be hospitalized and on IV heart medicine for a short period of time. So it's not a medication that's used in the long term thinking that you're going to make the function better, and then it's more a medication used to support a patient short term, sometimes long term. But if a patient is requiring IV medications for heart function, that is the time where we may discuss candidacy for therapies like a ventricular assist device, which is a heart pump, or sort of discuss like goals of care, and what the patient, your son, sort of what their goals are in their care. Hope that answered your question. Any other questions?
Well, if that's it for questions, I think we can go ahead and begin closing here. Dr. Weber, thank you so much for your presentation and answering questions. The entire Duchenne community appreciates it and all that you do. And
thank you.
Yes, of course. And thank you all for joining us our Jet Foundation virtual workshop series today. This presentation will be recorded and uploaded to our website if you would like to watch it again or share with others in the community who could benefit from it. For any other questions you may have, please feel free to reach out to us, and we look forward to seeing you soon. Thank you again and have a great week.